Hey everybody, this is our chapter on skin integrity and wound care. Wound care, you really only get in block 1 until you get to burns in, I believe, block 3. So it will be a good portion of your exam, and I would recommend that you really spend some time getting to know about wounds and wound care. When you're in your long-term care facilities, make sure that you spend some time with your wound care nurse as well, because they're going to teach you so much awesome stuff. Here's your objectives for this particular chapter. Make sure at the end you can go back and review those and speak to them in your own words. This is a little diagram of the structure of the skin. You have the epidermis, the dermis, and the subcutaneous layer of skin or tissue. The epidermis is the protective waterproof layer of keratin. This right here. And it's your first defense. Your skin is obviously your largest organ, if you remember that from A&P. It typically regenerates easily and quickly. The dermis is made up of that elastic tissue. That is collagen. And you do have nerves and hair follicles and blood vessels in this layer. And then the subcutaneous layer anchors the skin layers to the underlying tissues. This slide reviews the structure and function of our skin. The epidermis is the outer portion, which I was just saying, and it's actually made up of 5 layers. The outermost layer is composed of mainly dead cells, and it functions as a barrier. The innermost layers continually produce more cells, pushing the older ones to the surface. Deeper are the layers that produce melatonin. The dermis lies beneath the epidermis and above the subcutaneous tissue. It provides elasticity and strength to the skin. Within the dermis are the sebaceous glands, sweat glands, wax glands, hair and nail follicles, sensory receptors, elastin, and collagen. The subcutaneous layer is composed of mainly connective and adipose tissue. It provides insulation and protection. Breaks in the skin increase the risk for infection. Remember, I said skin is the largest organ and it's our first barrier against infections. The skin has many functions. It's a barrier to water, microorganisms, and ultraviolet rays. It protects us against infection, and it protects the underlying tissue and holds moisture in. I feel like that's a great select all but apply question. It regulates temperature through evaporation of perspiration, the dilation and constriction of tiny blood vessels, and it has hair in it to help with insulation. It contributes to our self-esteem and appearance, and it provides us an identity. It tells us where there's pressure, hot, cold, pain, and touch. There is a precursor to vitamin D in the skin, and it excretes water, electrolytes, and nitrogenous waste through sweat. This information can also be found in your book. Basic principles related to integrity of the skin and mucous membranes are listed on this slide. Pause and take a moment and read through them. The developmental considerations are listed on this slide. As a person ages, the maturation of epidermal cells is prolonged, leading to thin, easily torn skin. There is also a decrease in the subcutaneous tissue under the skin, giving it a more transparent look. You are also more vulnerable for tissue damage from pressure. Your state of health and well-being have an effect on the condition of your skin. Some of the different causes of skin alteration are listed on this slide, so take a moment and go through it. Remember, proper nutrition, adequate circulation, and good overall health are important for healthy skin. As your largest organ, of course, it's going to show when you don't have good health over time. Older adults have age-related changes to their skin, like the thinning of dermal and subcutaneous tissue, pigment changes, cell renewal changes, the decrease of sweat glands, and the collagen becomes disorganized. These changes require special nursing strategies in the care of their skin. Please go to the box labeled Focus on the Older Adult in your text and read through the details of the special care they need. Wounds are classified in different ways based on how they were acquired, the length of the time of the wound, and which portion of the dermis is affected. The first one we will go over is intentional versus unintentional wounds. An intentional wound is a result of a planned invasive procedure through the skin. This could be from surgery, IV insertion, or various punctures. The edges are clean and bleeding is controlled. Unintentional wounds result from some sort of accident or trauma, and they're not planned. These could include cuts or shots or other injuries from things like automobile accidents. These edges are usually jagged and are at risk for uncontrolled bleeding and are not in a sterile environment. A wound is considered open if there is a break in the skin or the mucous membranes. Open wounds include abrasions, lacerations, puncture wounds, and surgical incisions. If there are no breaks in the skin, the wound is described as closed. Contusions, which are bruises, or tissue swelling from fractures, are common closed wounds. So know the difference between an open or a closed wound there. Acute wounds are expected to be of short duration. In a healthy person, these wounds heal spontaneously without complications through the 3 phases of wound healing. Those 3 phases are inflammation, proliferation, and maturation, which we'll get to. Wounds that exceed the expected length of recovery are classified as chronic wounds. They can also be partial thickness, where it does not go through all the layers, full thickness, where it does go through all the layers, and complicated if it's mixed and extensive. If partial thickness wounds, in partial thickness wounds, regenerative epithelial healing takes place. No scar forms, and the new epithelial and dermal cells form new skin that cannot be distinguished from the intact skin. Partial thickness wounds, by regeneration, let's see. When a wound involves minimal or no tissue loss and has edges that are well approximated or closed, I would know that term, primary intention healing takes place. Little scarring is expected. A clean surgical incision heals by this method. Neuropathic ulcers occur when a patient with poor neurological function of the peripheral nervous system has pressure points that cause ulceration through the epidermal and dermal tissue layers. This is a common condition in the foot and occasionally other body parts. Vascular ulcers are wounds on your skin that develop because of problems with blood circulation. They are most common on your extremities, especially your lower legs and feet, but they can also develop elsewhere on your body. These wounds can take a very long time to heal and may need specialized treatment, including surgery. Bed sores, also called pressure ulcers and decubitus ulcers, are injuries to skin and underlying tissue resulting from prolonged pressure on the skin, typically bony prominences. Bed sores most often develop on skin that covers bony areas of the body, such as the heels, ankles, hips, and tailbone. People most at risk for bed sores have medical conditions that limit their ability to change positions or cause them to spend most of their time in a bed or a chair. Bed sores can develop over hours or days. Most sores heal with treatment, but some never heal completely. I want to also mention here that you can also have pressure injuries if you're wearing, you can get a pressure injury from lines, tubes, and drains. So it's very important that as healthcare providers, we are assessing our patient and looking under the covers to make sure that they're not laying on something that is pressing into their skin, because it could cause a pressure injury as well than just their bones. Pressure injuries can be classified using a staging system. So stage 1, you will need to know these as well as how they're treated. Non-blanchable erythema. So what that says is, I roll you over. The most common area we see this is the coccyx. I roll you over and I notice that you have some redness near the tailbone area, the end of your spine. I push on it and it does not blanch, meaning it doesn't turn white. It stays red. That indicates that there's some damage to that layer. So that is a stage 1 pressure injury. The skin is still intact, but it is non-blanchable and it's red. Stage 2 is a partial thickness skin loss. Stage 3 is full thickness skin loss. Stage 4, full thickness tissue loss. And here is how we classify by the colors of our open wounds. Open wounds or wounds healing by secondary intention can also be classified using the RYB system. R stands for red. Red wounds are in the proliferation stage of healing and reflect the amount of granulation tissue present. So that's a good stage to be in. They need protection and gentle cleansing and use of moist dressings, being changed only when necessary. Y stands for yellow wounds, and it indicates the presence of exudate or slough, and it requires wound cleaning. There is usually oozing of purulent yellow or white or beige drainage. These wounds require wound cleansers and irrigation. B stands for black wounds. This indicates the presence of eschar tissue or eschar. I never say it right. Just know if I say eschar or eschar, that's what I mean. This is usually black, but it could be brown, gray, or tan. The eschar requires debridement from an advanced practice nurse or other provider. It's someone who has certification in taking care of the wound and doing the debriding. Debriding a wound is the removal of devitalized tissue. Devitalized as in it is not doing while it's not alive, or foreign material from the wound. It also helps remove cells that are alive but not functioning or sentient from the wound bed and edges. Removal of necrotic tissue, exudate, and infected material helps stimulate wound healing and prepare the wound bed for advanced therapies or biological agents. You must have provider's orders for any type of wound debridement, and you should begin, hang on, I lost my place here. You should be an advanced practice nurse or a wound care nurse to carry out sharp or mechanical debridement. Sharp debridement is the use of a sharp instrument such as a scalpel or scissors to remove devitalized tissue. This method provides an immediate improvement of the wound bed and preserves granulation tissue. Mechanical debridement may be performed via lavage, the use of wet to dry dressings, or hydrotherapy, like a whirlpool. Enzymatic debridement uses proteolytic agents to break down necrotic tissue without affecting viable tissue in the wound. To use an enzyme product or an enzymatic product, clean the wound with normal saline, apply a thin layer of the cream, and cover with the moisture retaining dressing. Autolysis debridement is the use of an occlusive moisture retaining dressing and the body's own enzymes and defense mechanisms to break down necrotic tissue. This process takes more time than the other techniques, but it is tolerated better. The procedure involves applying the dressing and observing the fluid that collects under it. Wound fluid may be tan in color. The dressing is normally changed every 72 hours. At that time, the wound is cleaned before a new dressing is applied. Your text has a picture of these types of wounds and their related tissue appearance. Pause, take a moment, and review that information. The principles of wound healing are listed on this slide. Pause and take a moment to review this information. There are also phases of wound healing. The first is hemostasis. This occurs immediately after the injury. Blood clotting begins through platelet aggregation. Plasma and blood leak out into the injured area and create a liquid called exudate. The accumulation of exudate causes swelling and pain. Area blood vessels react by constricting to limit blood loss. Platelets clump to slow the bleeding, and the clotting mechanism is activated. The inflammatory phase is the next immediate phase, and it lasts between 4 to 6 days after the injury, and it consists of inflammation. In the inflammatory process, white blood cells migrate to the wound tissues and cause edema, erythema, pain, and possibly a temperature elevation. Then phagocytosis begins, and a scab is formed. In the proliferative phase, which occurs about 5 to 21 days after the wound develops, cells develop to fill in the wound. Fibroblasts form collagen, and granulation begins. The maturation phase is the final phase of wound healing. It begins in about the 3rd week, and it lasts many more months or even years. The collagen fibers are broken down and remodeled into scar tissue. This scar tissue is less elastic and still not as strong as the original tissue. Here's some more information on what I just said, basically. Macrophages enter the wound and remain for an extended period. They ingest debris and release growth factors that attract fibroblasts to fill in the wound. That is the inflammatory phase. And this is pretty much what I just said about the proliferation phase. Maturation phase. There are many factors that affect wound healing. We've talked about many of them in class already. These include things that occur directly in the wound, like pressure, which disrupts the blood supply to the wound. Desiccation is when the cells dehydrate and dry up and die in a dry environment, and that's why wounds are kept moist. So desiccation we want to avoid. You know how you always think you want a scab to form? Well, you probably do on a healthy person that just has a surface area abrasion or something. But when you have a deep wound, you want it to stay moist as it heals. So you don't want a scab in those deeper wounds. Maceration is the softening or breakdown of skin when it is exposed to moisture. All of these terms you need to understand and know, because you're going to want to be documenting your wounds as a nurse, and you need to know what these terms mean. Trauma results in delayed healing. Edema interferes with the blood supply. So the wound doesn't get a good blood supply, so it's not going to heal very well. Infection steals the patient's energy with an immune response, and it doesn't leave much left for healing. Excessive bleeding interferes with space in the wound and oxygen diffusion to the tissues. Necrosis, or dead tissue in the wound, will not allow the wound to heal, and it must be removed by debridement. Biofilm is a thick film of bacteria mixed with sugar and proteins. This barrier prohibits wound healing and promotes chronic inflammation. Systemic factors can also be a factor in wound healing. The older you are, the slower your healing, along with being exposed to possible chronic illness, which can interfere with healing. The older adult also has age-related changes like loss of turgor, decreased sensation, and increased risk of infection. These require special nursing interventions. Pause and take a moment and read through these interventions in your box. The box is called Focus on the Older Adult in your text. And P.S. When you're looking through your textbook at all those boxes, because the boxes are where all the really good information is, make sure you're reading the Focus on the Older Adult, because that's what we're focused on in Block 1, and you can know that you're going to need to know those things. Impaired circulation and oxygenation to the tissues prolongs healing also. So remember, your diabetic patients, that's why they have more of a risk of amputation, because they have impaired circulation and oxygenation. If your circulation is impaired, so is your oxygenation. Your nutritional status plays a factor also. Wound healing requires adequate, good to know, protein. That's probably the biggest thing. Carbohydrates and minerals in the diet to rebuild cells and tissue. Your overall health status will also play a factor. If you are immune compromised or immunocompromised, immunosuppressed, it can delay your wound healing. The use of medications like corticosteroids delay healing, or the use of chemotherapy agents or radiation will delay wound healing also. Here's some wound complications. There are various complications that can occur when wounds are healing. Infections can occur due to the location of the incision or being exposed to various bacteria in a healthcare setting. Symptoms usually start 2 to 5 days after the injury or the surgery. Their signs and symptoms include increased drainage, sometimes purulent, pain, swelling, and redness at the site. So, drainage, pain, swelling, redness. You can also have a fever and an increase in your white blood cell count. Why? Because it's an infection. The risk of hemorrhage is greatest in the first 24 to 48 hours following surgery or injury. Swelling of the affected body part, pain, and changes in vital signs. For example, decreased blood pressure, elevated pulse, may indicate internal bleeding. By internal bleeding, in this chapter, we are referring to a hematoma, a red-blue collection of blood under the skin, which forms as a result of bleeding that cannot escape to the surface. External hemorrhage is easier to recognize. You will see blood drainage on the dressings and in the wound drainage devices. When there is a brisk hemorrhage, blood usually pools underneath the client as the dressings become saturated. Rupture or separation of one or more layers of a wound is called dehiscence. The picture on the slide marked A is a dehiscence. So, this is all put together with staples or it's sewn together. And now it has split apart. So that can occur if the patient sits up or if they cough without splinting, or just if their incision isn't healing properly, it eventually can dehisce. The most common causes of dehiscence are poor nutritional status, inadequate closure of the muscles, or a wound infection. Evisceration is total separation of the layers of a wound in which internal viscera protrude through the incision. So here you have a piece of the bowel protruding out of the wound or through the incision. This is a rare complication and is a surgical emergency. Immediately cover the wound with sterile towels or dressings soaked in sterile saline solution to prevent the organs from drying out and becoming contaminated with environmental bacteria. So I would definitely know if you have a wound that is an open abdominal wound, you need to keep that moist. Why? Because the internal organs are moist. If you put dry materials over it, you're going to dry it out. We do not want to dry out our bowels. That would be a bad thing. Fistula formation is an abnormal passage connecting two body cavities, or a cavity and the skin. Fistulas often result from infection. An abscess forms, which breaks down surrounding tissue and creates the abnormal passageway. Chronic drainage from the fistula may lead to skin breakdown and delayed wound healing. The most common sites where fistulas are formed are in the gastrointestinal and genitourinary tracts. So, for example, if you have someone that perhaps has, I'll say they have colon cancer. Their colon cancer causes their bowel to, the cancer adheres to their bladder, and now you have a fistula forming between the bowel and the bladder. So you're passing feces through the urinary tract. Sometimes that's the person's first indication, other than maybe some pain that is general and not maybe looked into, that you actually have cancer in that area. Same with GI, if you have different chronic illnesses that cause inflammation, and that could cause fistulas between different areas of the bowels. So now you have a hole in the bowel and it's leaking into the peritoneal cavity. All right. Here's what the signs and symptoms are of the presence of infection. The wound is swollen. It's red in color. It's deep red actually, sometimes purple. Wounds can feel hot on palpation and even the surrounding tissue. Drainage is increased and possibly purulent. When I say purulent, that means it has pus present in the wound. It can be a variety of colors, and it does not smell very good. That's purulent, and that is the medical term for pus in the wound, purulent drainage. Foul odor may be noted. Wound edges may be separated with dehiscence present. So when I say the wound edges may be separated, if it's approximated, it's now separating. Dehiscence is where the staples or the sutures are coming out, and they shouldn't be. If you have an open wound, the wound edges could be lifting so that you could take a Q-tip and put it underneath that layer, and it goes in 1/2 inch all the way around. That's separation of that first wound edge layer between the skin and the wound edge. An estimated 1 million people in the United States have pressure injuries, about 15% of hospital patients, 10% of home care patients, and 20% of long-term care patients. Pressure injuries are 100% preventable. Unless the pressure injury is present on admission, in most circumstances, Medicare will decline payment for treatment for that ulcer. Costs in living can be high as well, with reported mortality rates of 70% for older adults within 6 months of an occurrence of a pressure injury. Certain intrinsic factors alter skin and tissue integrity or oxygen delivery capabilities, decreasing the amount of force required to create a pressure injury. Examples include immobility and impaired sensation, as occur with spinal cord injuries, strokes, or coma, poor nutrition, edema, aging, low arteriolar pressure, that's hard to say, and fever. Poor nutrition or dehydration can weaken the skin and lead to pressure injuries. Adequate intake of calories, protein, vitamin C, and zinc, I would probably know those 4 things, is necessary to prevent pressure ulcers and promote healing of injured tissue. There are several extrinsic factors that come into play also. Friction damages the outer protective epidermal layer, decreasing the amount of pressure needed to develop skin lesions. Pressure injuries most commonly develop over bony prominences, but they can occur under casts, splints, or other assistive devices. Skin is compressed between the bone and the hard surface of the bed or chair, reducing blood flow to the area. When the patient is supine, these pressure points are the occipital bone, the scapula, elbows, sacrum, and heels. Shearing occurs, by the way, know the difference between shearing and friction. Shearing occurs when the epidermal layer slides over the dermis, causing damage to the vascular bed. It is most commonly occurring when the head of the bed is elevated and the patient slides downward, causing shear to develop in the sacral area. Exposure to moisture, especially in the form of urine or feces, moisture macerates the skin and also decreases the amount of pressure required to produce an injury. Hi there, I had to take a small break, so I'm going to pick up on this slide. I'm sorry if I've already said this. Pressure injuries, risk for development. There's your 4 major categories that cause risk for pressure injury development. And then there are the mechanisms of how they develop. Preventing pressure injuries. If you're going to work with an older population, you will be doing all of these things. I don't think that I need to read them to you, but let me look and see if I need to clarify anything. Not only are we going to assess our patients daily, we're going to make sure that we are bathing them and keeping them clean, especially those that have incontinence of bladder or bowel, because The acidic nature of the urine and the feces can break the skin down so quickly. As a matter of fact, I'm going to tell you right here, I don't ever want to see a patient in a brief on a chuck. They have one or the other. So I would prefer no brief and have them on one chuck. The more layers they have, the more at risk they are for skin breakdown. And we want to teach the patients, if they're going to be getting better and they're going to go home, how to keep their own skin clean and how to assess their skin. I feel like nutritional supplements, I mentioned those things. What did I say they were? They are protein, zinc, vitamin C, and I think, and good carbs, which is not a nutrition supplement, but you know what I'm saying. And then we have the staging. I mentioned staging earlier in this presentation. So it's always staged to the degree of the tissue involvement. And we only stage wounds that are caused by pressure. As our staged pressure injuries heal, they do not go down in stage, because once they've had a stage 4 full thickness skin loss with extensive destruction, even if that does fill in, it doesn't fill in with the kind of tissue they had before. So if they had a stage 4 pressure injury, their chart would reflect a healed or healing stage 4 pressure injury. The injuries heal by granulation tissue filling the wound, but you still have lost dermis, subcutaneous fat, and sometimes muscle, like you can sometimes see down to bones and tendons. Therefore, reverse staging does not accurately describe what is physiologically happening in the ulcer. A stage 4 injury will always be a stage 4 pressure injury, just healing. So go to your book and follow along with me and look at the animations and the pictures of the actual pressure injuries. A picture does paint 1,000 words, and my words are not going to make a lot of sense unless you can see pictures. And I'm not going to, well, I guess I'll read all this to you because you're going to be looking at the pictures. A stage 1 pressure injury is a discolored area, usually over a bony prominence that remains discolored for over 30 minutes after the pressure is relieved. It is usually painful. It can be soft or firm, warm or cooler than the surrounding area. The skin is still intact, but it is red and non-blanchable. A stage 2 pressure injury involves partial thickness loss of the dermis. They are open, shallow, and have a reddish pink wound bed. So think about you're cleaning your patient who is incontinent of bladder and bowel, and they already have a stage 1 pressure injury, and you have put a barrier cream on their bottom, and you're wiping their bottom, and when you wipe the feces off, you notice that now their skin is open over that wound. That is now gone from a stage 1 to a stage 2 pressure injury that fast. Stage 3 pressure injuries have full thickness skin loss with damage to the subcutaneous tissue. It may extend through to the fascia. Bones and tendons are not visible. So that is a distinguishing factor of your stage 3. You cannot see bones and tendons. Stage 4 pressure injuries involve extensive skin destruction with tissue necrosis or damage to the muscle, bone, or support structures. The exposed bones or tendons are palpable. There may be eschar tissue or sloughing of tissue. There are oftentimes tracking or undermining occurring underneath the dermis. They take the longest to heal, often up to a year. You can also have a suspected deep tissue injury that has an area of skin intact, but it is discolored. It can be purple or deep red, and it usually feels boggy, or it has a blister covering it. An unstageable pressure injury involves full thickness skin loss, but you cannot view the base of the wound. So full thickness skin loss, but you cannot view the base of the wound. Deep tissue pressure injury is a persistent, non-blanchable, deep red, maroon, or purple discoloration. The skin will feel boggy or not as firm as it should be. It's different than the surrounding tissue. I feel like that kind of gave you an idea. Hopefully you're finding pictures of unstageable. Basically, it's completely covered, so I can't see what's underneath it unless I debride the wound. And we are not doing it because we are not certified. All right. The push tool is used in assessing the healing or regression of a pressure ulcer. Here is an example of that tool. The Braden scale is what we will use and what we use all the time in the healthcare system. We will do this activity in the classroom using the Braden scale, so you can get some experience using it. But you're scoring your patients on a scale of 1 to 4, with 1 the worst and 4 the best. So does your patient have problems with sensory perception? And it gives you exactly what that means. And then you pick. And then you have moisture. Are they constantly moist? Because they are diaphoretic and they are incontinent, and maybe they have extreme edema that is weeping, that is constantly moist. Versus, are they rarely moist? Their skin's usually dry. They only have to have their linen changed at routine intervals, not like 10 times a day. Activity, they're bedfast, or are they walking frequently and independent? Mobility, completely immobile. They can't even make slight changes on their own to no limitation. Nutrition is very poor, and it tells you what that means, versus excellent. And then friction and shear. Is it a problem, a potential problem, or no apparent problem? And then you add up your score based on how you scored them. Oopsie, I totally just flew by that. We will talk more about the Braden scale, and specifically when we start to worry. Like, when do we start actioning a score? So what's the highest score that they can get? 4, 4, 4, 4, 4. So that is 23. So 23, we're not worried. They're awesome. But what if I had 3, 3, 3, 3, 3, 3? So 5 threes is 15. And then 16, 17. Would I start worrying at 17? I might. If I have 2s, I'm definitely going to be putting in some stuff in place, and 1s, absolutely I am. It's actually not a potential problem at this point. It is a problem. All right. The psychosocial issues related to coping with chronic wounds also need to be considered. There is always pain involved with the wound. I shouldn't say always, because you might have diabetic patients with neuropathy that have lost the sensation in their lower extremities, and they have a wound and they don't feel it. That's half the time why it gets so infected before they even notice. And it's also why we tell them to look at their feet every day. But most people will have pain involved with the wound. Anxiety and fear about the wound opening, getting worse or infected, the costs associated with its care, and possible future scarring are all issues, depending on the person. They may have an impact on the patient performing their ADLs independently. And the patient may feel their body image has changed, and they might feel ugly or have a diminished self-worth. You will need to conduct a nursing history and assessment to assess wound healing ability and the risk for skin breakdown. You will need to gather data on factors that affect skin integrity, such as age, mobility, nutrition, hydration, sensation, circulation, medications, moisture, lifestyle, cognition, underlying health and disease status, and the presence of microorganisms. The psychosocial issues related to coping with chronic wounds also need to be considered. The Braden scale you should remember from clinical lab earlier in the year. It is also in your textbook in this chapter. We just went over it 2 slides ago. The Braden scale evaluates 6 major risk factors, which we just talked about. And nurses typically, at least on the floors I've worked, do a Braden scale every shift on every patient. So we use the scale to assess the patient on admission to the facility, and again in 48 to 72 hours according to this. Studies have shown the second score to be more predictive, probably related to increased awareness of the patient's status. That's true. Like when they first come in, do you actually know all the stuff that you're marking them down on? So you err on the side of caution. That second one that you do, you've had more time to observe, you've had more time to assess, and you can probably fill it out more accurately. Skin assessment should happen at specific intervals depending on the type of healthcare setting the patient is in. In acute care settings, the assessment should take place on admission and then at least every 24 hours. In the long-term care setting, it should be done on admission, and then if the resident is not at risk for pressure injury development, it can be done in depth at least every 4 weeks or whenever the resident's condition changes. In home health care, it is done on admission in every home care visit. Other things to assess include any recent changes in skin, the patient's decrease in their activity level and mobility, and the patient's nutritional status. How much protein are they getting? Do they have any pain? And do they have problems with elimination? Or are they incontinent? And these are how we do our skin assessments. Remember how I said, okay, head to toe, just like we do our assessments, but this is just looking at skin. Include all the bony prominences. If they're on oxygen, check behind their ears, across their nose, and in their nose. Acute care, those are the typical intervals where we do them. One thing I wanted to say about, we do a skin inspection with 2 nurses, typically, at least in the hospital, and it's by policy. Because, remember I said, if there is a pressure injury on someone, or really if they have wounds at all, if they were present on admission, then we are not held accountable to the cost of those wounds. However, if they were not present on admission and they develop an injury or a wound during their admission, then we are not reimbursed for that in the facility. So that's why 2 nurses within 24 hours have to completely assess every square inch of someone's skin and say this patient has all of these injuries or none of these injuries, so that we can either be held accountable or not be held accountable to existing wounds. So when you are documenting the wound, you need to document all of these things and more. You're going to describe the wound's location in anatomical terms. Location influences the rate of healing. Wounds in highly vascular regions, such as the scalp or the hands, heal more rapidly than wounds in less vascular regions, such as the abdomen or a heel. Location affects movement. Wounds that can be readily stabilized heal more rapidly than in areas that are affected by the constant stress of movement. So if you have a crack in your skin at a joint in your, like the joint in your thumb, you're constantly moving your hand. That's going to take longer to heal because you're constantly moving it. Same with like you have a wound, say, I don't know, in the groin area and you're walking. So it's going to take longer for that to heal. Abdomen, you're constantly coughing, or you're just breathing. That is moving. Let's see. Location can give you clues to the wound etiology. So how did this wound occur? A wound over a bony prominence could be related to pressure, whereas one on the bottom of the foot could be a diabetic foot ulcer. You have to measure the length and width of the wound in centimeters using a head-to-toe orientation. The longest length, head to toe, and the widest width, side to side, perpendicular or 90-degree angle to the length, encompassing the entire wound. What is its appearance? Examine the wound's edges and the skin surrounding the wound. Skin discoloration may indicate a hematoma or additional injury to the surrounding tissue. Is there any tunneling or undermining or tracking of the wound under the skin? This information can be found in your textbook, and you'll want to know those terms. Assess the wound for any signs or symptoms of complications, and if there are any unusual odors. Clean wounds typically drain serous exudate. It is watery in consistency and contains very little cellular matter. Serous exudate consists of serum and straw-colored fluid that separates out of blood when a clot is formed. Sanguinous exudate will be present with deep wounds or wounds with higher vascular areas, or in higher vascular areas. Sanguinous exudate is bloody drainage. It indicates damage to capillaries. Fresh bleeding produces bright red drainage, whereas older, dried blood is a dark red-brown color. Serosanguinous is a combination of bloody and serous drainage. Purulent drainage is thick, often malodorous drainage that is seen in infected wounds. It contains pus, a protein-rich fluid filled with white blood cells, bacteria, and cellular debris. It is commonly caused by infection from pyogenic or pus-forming bacteria, such as streptococci or staphylococci. Normally, pus is yellow in color, although it may take on a blue-green color if the bacterium Pseudomonas aeruginosa, aeruginosa is present. Note any drains, tubes, or complications. I think we're getting there. Here are some nursing diagnoses associated with skin integrity. Pause and take a moment to review these and look these up in your Lippincott resource. Also refer to your text for some generalized possible patient outcomes that you could use when you're working with your patients. I'm just going to say you probably will have a patient, I can't imagine that you won't, that has a pressure injury. So these are good ones to look at. Okay, nursing interventions. So what are you going to do about it once you've identified the issue? The first thing is to prevent any pressure injuries from developing. Pressure injuries are 100% preventable, which we said. So do you think maybe they're a never event? I think they are. That's one of those sentinel events. We have to document it as an incident report when there's a new pressure injury. It is the nurse's responsibility to make sure that pressure injuries do not happen and that we take action to prevent them. So I'll say that again. It is the nurse's responsibility. If someone develops a pressure injury, it is all because of a lack of nursing care or poor nursing care. Nursing assessments need to be thorough and frequent. The patient should be supported to maintain good skin cleansing and hygiene. Use mild cleaning agents with warm water, rinse and dry thoroughly, and apply protective skin barriers if the patient is at risk for maceration of the skin from wound drainage or incontinence. Avoid massage over bony prominences. Do not massage. Position the patient appropriately to avoid shearing forces and use proper turning and transferring techniques. So when you are boosting your patient, don't drag them up the bed. Get help, pick them up, and move them. Make sure the patient is getting adequate nutrition and administer supplements as necessary. Get the patient up and moving if possible. Provide frequent position changes and range of motion as necessary. And of course, document all of your interventions and the patient's response to them. This information can be found in your textbook. Wound management includes keeping the wound clean, moist, and providing appropriate dressings that protect the wound, keep it moist, and help provide pain relief. You should also teach your patient the principles of medical asepsis, and get them involved in their own wound care whenever possible. Don't forget to provide emotional and psychosocial support through the process. This list on this slide provides various purposes of wound dressings. Pause and take a moment and look that over. There are several types of dressing materials for various wounds. We're going to talk way more about this in class. Gauze dressings can be used for covering wounds, most commonly surgical wounds. They come in various sizes like 2x2s and 4x4s and 4x8s. They're often put down using 3 layers. The first layer can be dry or moist and is meant to absorb any drainage, and then 2 more layers to absorb and protect. Sometimes wounds need to be packed with saline-soaked gauzes covered by protective layers. There are non-adherent gauzes, including taffeta and petroleum-soaked gauze. Transparent film dressings allow for an exchange of air and water vapor between the wound and the environment while preventing external bacterial contamination. They are useful for wounds with minimal to no drainage. They are often used to dress IV sites. It's also good because it allows us good visualization of the site. Some gauze dressings are impregnated with antimicrobial agents, medications, or moisture, and others contain petroleum to keep the wound moist. Hydrocolloids are wafers, pastes, or powders that contain hydrophilic or water-loving particles. When applied to a wound, the hydrophilic particles interact with exudate to form a gel that keeps the wound moist. The dressing forms a protective layer against friction and bacteria. This type of dressing is ideal for wounds with minimal drainage, such as partial thickness wounds or stage 2 pressure ulcers. Hydrogels, these are sheets, granules, or gels with a high water content that create a jelly-like consistency that does not adhere to the wound bed. Their soft, cooling texture promotes patient comfort. Hydrogels enhance epithelialization by providing moisture to the wound bed. They may also be used to soften, slough, or eschar in necrotic wounds, and they can be used in infected wounds. They are often used for burns, necrotic wounds, and wounds with minimal exudate. Alginates absorb exudate, maintain a moist environment, facilitate autolytic debridement, and can be left in place 1 to 3 days. They do require a covering dressing. They are used in wounds with moderate to heavy exudate, tunneling wounds, and moist red or yellow wounds. So your moist wounds, basically. Foams maintain a moist environment, do not adhere to the wound, and they are highly absorbent. They can be left in place for up to 7 days, but they may need a covering dressing to secure it. They are used for wounds with heavy amounts of drainage and can be used around tubes or drains, but not intended for wounds with dry eschar. Foams are used in negative pressure wound therapy. Go to your text and read about negative pressure wound therapy, as you might see this in some of your patients in the higher blocks. It is pretty interesting and pretty state-of-the-art in wound care. Actually, you might see it in your long-term care residents or your acute care rehab patients as well. Antimicrobials reduce or prevent infection. These are used for draining, exuding, and non-healing wounds and chronic wounds. Collagens are absorbent. They maintain a moist environment and do not adhere to the wound. They are compatible with topical agents, conform well to the wound surface, but they require a secondary dressing to secure it. They are used for infected or non-infected wounds, skin grafts, donor sites, tunneling wounds, moist red and yellow wounds, and wounds with heavy exudate. Changing the dressing. We'll get some practice at this. We definitely will be doing a very simple dressing change when we do our day in the life in block 1. We're going to change our gloves a few times while we're changing dressings. So preparing the patient. If they have pain, part of preparing them is making sure that they have had their pain medication in an appropriate amount of time so that it's taking effect when we're going to be cleaning the area and redressing it. Use appropriate aseptic techniques so you do not contaminate the wound bed inadvertently. Hand hygiene before and after. I want to say here that when you remove the old dressing, 1, remove it very gently and face it away from your patient's side so that they don't see the exudate, and watch your facial expression. If it's really, gnarly and you're not used to it, watch it, keep it, poker face. After you've removed the dressing, just go dispose of it appropriately and take off those gloves, wash your hands. Now you're going to clean all of that with whatever they tell you to clean it with new gloves on, of course. And then measure the wound and be ready to describe it for when you're going to chart. Then when you apply the new dressing, you're going to take your gloves off, do your hand hygiene, and then apply the new dressing however it is ordered to be placed and secure it without going overboard. Remember that part of what's not here is that you want to put your initials and the date and time that you changed that dressing. So that can go on a piece of tape that you write on before you place it on your patient. Don't autograph your patients, please. This slide reviews how to remove a dressing. Pause and take a moment and go through it. I am pretty darn sure that you will have videos as well if you look through Lip and Cut. And then this is cleaning a wound or a pressure injury. So we always clean the wound before applying a new dressing. We can use normal saline and irrigate the wound with a large volume syringe. We let it flow into a container, or we gently use a normal saline soaked gauze or a swab. If you have a long wound, we'll swipe from the top to the bottom, starting at the middle and then working our way out. If it's a round wound, we use a circular motion from the middle on out and beyond about 1 inch. Actually, I've seen other things that say that you should do it a different way, but we'll go with this. Use a new gauze or swab stick for each new swipe or circle, so you're not using the same cloth and infecting other areas with the bacteria that you got off of one area. You can find the details on this in your textbook. Then you would apply the new dressing using the proper order dressing, apply the skin prep using the proper technique while following manufacturer's directions and adhering it appropriately. Some wounds will need to be packed. Go to your textbook and read through applying a new dressing, packing a wound. We will demonstrate this next week. Lastly, we have to secure the dressing. There are all types of tapes available out there. Make sure to select the type of tape that will adhere to your patient in the area you need to apply the dressing. Don't wrap them up like a Christmas package, but instead use minimal tape to do the job. Make a tab on each strip at the end of the tape for easy removal next time. You will need to use a piece of tape or a sticker that came with the dressing to do what I said on the last slide. Put your initials, time and date, and put it in the corner of your dressing. This is an easy way for the next person who is looking at your patient's dressing to see when it was changed and who changed it. So bandages are used to secure the dressing, apply pressure, and support the wound. Roll or gauze like Herlix or Clean can be wrapped about limbs or amputations. They can be applied using a spiral turn from the distal end of the limb up in a figure 8 turn. I showed you guys this in lab. Or in a recurrent manner. The pictures of these different techniques are listed on this slide. Take a moment and get to know them. So here's the figure 8 thing for a person who has had an amputation. This is a residual limb wrap. All right. And then we have binders. Different types of binders. I don't know that it's necessary to know all of the different types, but know that we use them in abdominal surgery. I feel like you can read and see a little bit more about those. We use slings to support arms. But basically the binder is to hold the abdominal tissues in place and decrease the risk for dehiscence or, I can't think of the word, but you know, when the intestines come out of the wound, which would be a bad thing. Types of drain systems. Open systems use a Penrose drain. They pull away extra fluid in areas enclosed areas to decrease the pressure and increase the healing. The drains can be either open or closed systems. And I don't see these very often anymore because really I feel like I saw them a lot in the hospital, but the Penrose drain is the one I think I see the most. This drain uses a passive movement of fluid and it drains into a gauze on the surface. No. That is not the type I see. This is that. I see this type. This is the type where I'm trying to look here to see what that one's called. Well, I don't know what it's called. It's not saying. I thought this is probably I think this is the Penrose string, this thing. You squeeze the bulb after you empty the contents, and then by that pressure that's created by that gradient of you squeezing the drain, it will naturally pull the exudate out of the wound and into the bottle, and as it does so, that bottle will expand. You need to really keep a close eye on that. We will always chart the output from the drain, the color, the amounts, the characteristics, and as you empty it into your graduated cylinder, you squeeze it closed and close it again. We do pin them to the person's gown so that they don't accidentally become dislodged. We might need to teach our patients about wound care and healing for when they go home. You'll want to make sure that you know what they will need to purchase for supplies and where you can get them. Be conscious of cost and availability. You may need to call in case management or social services to investigate if their insurance will cover the costs or if there are any resources for them. Instruct them on preventing infection and using medical asepsis. They will also need to know what a possible infection would look like and its signs and symptoms and who to call should this arise. They need to know about how to dispose of old dressings and the use of good hand hygiene and clean gloves. They will need to know about nutritional needs and the patient may have to support good wound healing. And the necessity to drink 6 to 8 glasses of fluid each day. Schedule in rest periods and modify their ADLs and activity until an increase in activity is approved by their provider. Also make sure they know how to medicate themselves appropriately prior to any painful dressing change. They can also take pictures of the wound on their phone daily to show the provider the healing progress or any signs and symptoms of infection that might occur. The last thing we're going to go over is the use of hot and cold therapy. We're going to cover this more in lab as well. Before applying heat or cold therapy, you need to consider some stuff. First of all, what are we using for the therapy for? And how long should it be applied? Next, you want to consider the degree of heat. You do not want it too hot or too cold, as that will do tissue damage. Always consider your patient's age and physical condition and what they could tolerate. Be prepared by knowing how much of the body surface you will need to cover in the application of the therapy. Heat dilates the peripheral blood vessels and increases tissue metabolism. It reduces blood viscosity and it increases capillary permeability, reduces muscle tension, and it can relieve pain. Cold constricts peripheral blood vessels, reduces muscle spasms, and promotes comfort, reduces edema and inflammation. If applying heat or cold, you want to do it 20 minutes on and 20 minutes off so as to not do permanent tissue damage. Assess the area frequently and test the temperature of hot applications prior to applying them to the patient. For heat, you can use hot water bags, aqua thermia pads, or warm packs. Your book talks about heating pads, but those are not recommended because of the amount of burns that they can produce. Moist heat includes warm, moist compresses, sitz baths, and warm soaks. Applying cold includes ice packs, cold packs, and cold compresses. Go to your textbook and review the procedures for each of these therapies and the wound care therapies so that you can get familiar with them in case you have the opportunity to apply these for your patients. Lastly, we would need to evaluate any intervention or therapy provided for if it worked or not. We want you to go through all the skills at the end of this chapter as listed on this slide and also watch the videos. This is the only time you will get this information, and you are responsible to learn and know all of this so that you can practice these skills in the clinical setting with your patients. This is finally the end of the chapter on skin integrity and wound care. Thank you.